All right, so this lecture is going to be on the history and the assessment for an individual with hematologic and lymphatic problems. So for the history, like I said at the beginning of the first lectures, you have to get a very detailed history, okay? So we're going to start our assessment with a thorough patient history. So to increase your patient's cooperation, of course, we always develop a trusting relationship with them. So let's ask our patient, why are they seeking medical help? You want to document the response in the patient's own words. And keep in mind that signs and symptoms of hematologic problems can appear in other body systems. So the patient's complaints may be nonspecific, such as a lack of energy, lightheadedness, or even nosebleeds. Nonspecific complaints aren't diagnostic in themselves. However, when you're considered in the context of a complete patient history, they can establish a pattern that suggests a hematologic disorder. You want to also ask about the patient's medical history, which may provide clues to their present condition. Stay alert for disorders such as acute leukemia, Hodgkin's disease, that necessitated aggressive immunosuppressant or radiation therapy. So you want to know, do they have a history of cancer that has led to some of these issues? If your patient was hospitalized, ask them why. It could be a previous surgical intervention, like a splenectomy, for example, that could be causing your medical problem at the moment. Has the patient received blood products? If so, you want to note when and how many he or she received to help assess their risk of harboring an infection transmitted by a transfusion, which, again, very rare. Finally, you're going to document all the medications that they're taking. Prescription, over-the-counter. Some medications interfere with various components of the hematologic system, and I think we've talked about this in other body systems, but you have to get a very thorough med list that includes everything that they could be taking. For family history, okay, you want to ask about deceased family members recording the cause of death and their ages at death. Note that hereditary hematologic disorders like hemophilia and sickle cell anemia would be very pertinent in this family history. We also want to ask about their social history. So you want to ask your patients about alcohol intake, diet, sexual habits, possible drug use, which can impair hematologic function, and exposure to such hazardous substances. Some of the common ones that you see that cause problems like benzene or Agent Orange, which you see in your military, which can cause bone marrow dysfunction, especially leukemia. So that occupational exposure would absolutely be something that would be important to take note of. We're going to look for vague complaints of fatigue, those bleeding tendencies, those respiratory symptoms, shortness of breath. Have you noticed any skin changes? Okay, so remember, I talked about red blood cell destruction can lead to jaundice. Okay, so for jaundice, you want to observe the patient in natural light rather than incandescent lighting, which can mask a yellow tinge. With a dark-skinned patient, you want to inspect the buccal mucosa, the palms, and the soles for a yellowish tinge. And in patients with edema, you want to examine the inner forearm for jaundice. It's going to be difficult to detect it that way. If you suspect a blood clotting abnormality, you want to check the skin for purpuric lesions or purplish spots and patches that can vary in size and usually result from, thrombocytopenia. With your dark-skinned patients, again, we're going back to that oral mucosa or your conjunctiva for petechia or ecchymosis, and I'll talk about those in another thing. Lymphadenopathy. Lymphadenopathy is enlarged lymph nodes. Okay, so you want to inspect the abdominal area, the liver, the spleen. You're going to inspect over the axillary region, the cervical lymph nodes, the femoral area. There's lots of areas that you can detect that lymphadenopathy in your patients. For your physical assessment, okay, we've always got to get some good vital signs. Okay, vital signs are going to be indicative of a lot of hematologic problems if you know what you're looking for. So you may have tachycardia, you may have tachypnea related to anemia, okay? You could have hypotension because we've got a decreased circulating blood volume. You want to assess the patient's level of consciousness. So remember, the first indicator of hypoxia is that restlessness and anxiety, and so you may have a change in their LOC. Skin color, like I mentioned in the previous slide, you're going to look at that skin color. Do we have a jaundice type situation going on? Are we very pale because we have iron deficiency anemia? You're going to look for those signs of bleeding. So like I said, the signs of bleeding we're going to talk about in this chapter, we're going to look for ecchymosis, we're going to look for purpuric lesions, we're going to look for petechia, we're going to look for hidden blood, okay? So we're going to look for any signs and symptoms of bleeding. Palpation of those lymph nodes, again, that's more advanced practice, but it's sometimes you'll have patients that'll have very, very enlarged lymph nodes. It's very, very easy to see those. For the fingernails, okay, you want to inspect their fingernails for striations, a spoon-shaped nail, maybe an abnormally broad or flat nail, or clubbing, okay? Those are all things that we would look at in the fingernails. And for the abdomen, if you want the patient lying down, you can auscultate the abdomen before we palpate so that we don't alter those bowel sounds. You're going to listen for loud, high-pitched tinkling sounds, which could be early stages of an intestinal obstruction. You also want to look over the spleen and the liver. You also want to make sure that you gently do a light palpation. We use only our finger pads. We move over the skin over each area. And as we palpate, you're going to note the location, size, tenderness, texture for whatever organ that we are lightly palpating. So we want to make sure that you always palpate tender areas last, okay? And then again, if you suspect that there is a tumor, you want to avoid continued palpation, okay? So just be really careful if you are going to be palpating patients, especially with suspected tumors. All right, let's talk about the diagnostic tests. Okay, so the diagnostic tests that we use for our patients with blood and hematologic is the CBC particularly. Okay, the blood test that we're looking at usually going to be a CBC. That's going to give you your white blood cells, your red blood cells, your hemoglobin, your hematocrit, your platelets. Those will all be in those specific blood tests. Now, there are other blood tests that we use here. We also have ABO blood typing, which is where you type the patient's blood type. It'll also give you your RH blood typing so that you can figure out, are we RH positive or are we RH negative? And then you've also got other different types such as your coagulation tests. Your coagulation tests are going to help you detect bleeding disorders and specific coagulation defects. So your commonly ordered ones are going to be your PTT, your bleeding time, your prothrombin time. There's also fibrinogen levels that would be helpful in detecting something called DIC. And we'll talk about those as we get closer to that chapter. Bone marrow biopsy. Okay, bone marrow aspiration and needle biopsy, we kind of lump those two together. Because most hematopoiesis occurs in the bone marrow, it's really important to get a thorough bone marrow examination, and it's a very valuable diagnostic tool about your blood disorders. So that bone marrow aspiration and needle biopsy are going to provide the material necessary for that type of test. The aspiration biopsy removes the fluid specimen that contains bone marrow cells in suspension. The needle biopsy will remove the marrow core that contains cells but no fluids. So the biopsy is going to be helpful in diagnosing like aplastic anemia, vitamin B12 deficiency anemias, leukemias, lymphomas, thrombocytopenia. It can also evaluate primary and metastatic tumors. It can determine the cause of infection. It can do staging of diseases like Hodgkin's disease. It can evaluate chemotherapy effectiveness. And so those are all reasons why we would do a bone marrow biopsy. So your nursing considerations for a bone marrow biopsy, and I'm going over this a little bit more in depth because this is something that tends to show up on your boards and your ATI. So when you're preparing your patient, explain that the test provides a bone marrow specimen for microscopic examination. You want to inform the patient that they do not need to restrict food or fluids beforehand. Explain that it will be about 5 or 10 minutes in length, and results are usually going to be generated within a day. You want to inform the patient that more than one bone marrow specimen may be necessary, and that before the biopsy, they'll need to give blood sample for laboratory testing. You want to check the patient's history for hypersensitivity to the local anesthetic and make sure that the medical record has assigned patient consent. After checking the patient, or after checking with the individual who will perform the procedure, you want to tell the patient which bone will serve as the biopsy site. Most commonly, for adult patients, we're going to use that posterior iliac crest. But I want you to go into your book and look at the other sites that we utilize, okay? I have seen in the past where they have said your patient is getting a bone marrow biopsy other than the posterior iliac crest, which of the following is an acceptable site. So you need to know the additional sites that we use for bone marrow biopsies. Make sure you tell the patient they'll receive a local anesthetic, but they will feel pressure when the biopsy needle insertion and a brief pulling pain with the bone marrow removal. Anytime I've had a patient who has had a bone marrow biopsy, they'll usually tell me that it wasn't as bad as they were expecting. Okay, a lot of people have a lot of fear about it. Tell the patients also they will a lot of times get a mild sedative before the test. And after the procedure, you want to check the biopsy site for bleeding and inflammation. So you'll observe the patient for signs of hemorrhage and infection. So that's your rapid pulse, low blood pressure, and then a fever. And you change the dressing over the site every 24 hours to reduce the risk of infection. So those are the big things I wanted to talk about in terms of a bone marrow biopsy, because like I said, they tend to ask you those questions a lot on your ATI and on your board exams, okay? Lymph angiography, this is where they're going to inject dye into the patient and get a really thorough look at the lymph nodes. You better tell your patients what's going to happen to them afterwards. It is not uncommon for them to have blue urine and feces up to 2 days after the procedure. This was something my mom actually had done when she was undergoing her treatments, and she kind of panicked when she had blue urine. So lymph angiography, that's one of the big side effects after it, is that you may have blue urine and feces for up to about 2 days afterwards. And lymph node biopsy, that's what we use for determining your lymphatic issues, metastasis from other cancers. Make sure you look over that in your book as well. I don't want to go into a whole lot of detail, but just understand that lymph node biopsies is how we a lot of times determine lymphomas and also metastasis from other cancers. All right, and I'm going to do a whole separate lecture on blood products.